but inevitably you have to. I think we're live. Hold on, let
Yeah,
me
that's
look.
what it says. It says live on, it says recording live on Facebook.
Alrighty. Okay, so let's do this.
Nice.
Amanda Williams, thank you so much for being here with me today. It's a thrill and super fun to have you talk today, and also to reach out to my audience of people who are listening to me blather on about mental health and physical health every day, which has been my great pleasure during the pandemic. The pandemic has also been a great moment in time for me to be able to reach people who I've known for a long time, like yourself.
Yay.
So, okay, hello everybody, I'm Lucy McBride. I am here today with my friend and fellow physician, Amanda Williams. And I'll just be a little bit about Amanda before I turn over the platform to her. Amanda is a board certified OBGYN in Oakland, California. She works in the Permanente Medical Group, and she's the director of maternity services. She is from originally Washington, D.C. We actually went to high school together. I'm a little older than her, but I will not, you know, lord that over her too much. Uh-oh, did I lose you? I lost your, there we go. Well, you're back. You're back. Went to Harvard University undergrad, did her medical training at Emory. She also got a degree in public health from Emory, and then she did her residency in OBGYN at the University of California, San Francisco. Her primary interests in medicine are family planning and collaborative obstetric practice. And she is going to tell you more about that herself. She also enjoys mentoring minority women. She practices yoga. She's a mother of 2 boys. She's basically just a really cool person. So Amanda, let you introduce yourself even more than I just did, and also explain to the audience, if you will, what is it you love about your job? What is it you do? What did you do before the pandemic? And what do you see as your role in the lives of patients? So those are a lot of questions. Shoot.
So what is your reason for being anyway?
Yeah, like what's the meaning of life?
Anyway, thank you so much for having me, Lucy. It's so nice to reconnect.
Yeah.
You know, even though we're sort of sequestered in our little virtual hovels, to stay positive and take advantage of it has been fantastic. So I think I'm really lucky. I have a very fulfilling professional life, probably too fulfilling. I probably do more of it. I love it, but I probably do more of it than I should. But I have direct patient care, still see patients, still do C-sections, deliver babies, all of that good stuff, about a third to a half of the time. And then I run the operations in our department. And then I oversee the pregnancy-related care for all of Northern California Kaiser. So one of the big things that's happening that's exciting right now is thinking about prenatal care redesign. And we insure 40% of all the pregnant women in California. So, you know, we
40%.
Yeah. So that's
a lot of people.
That's 2 million women who are insured by us. So it's great to be able to design with reach and design with mindfulness. I'm a big believer in looking at a more integrated view of what it means to be healthy. And I think you and I share this interest, and thinking about people's physical health, their mental health, what's going on in their communities, their families, their food, the social determinants of health, what's the impact of structural racism and their personal well-being, do they have the support that they need? There's a lot more that goes into keeping people healthy than the one-on-one 15, 20-minute visit that you have in the doctor's office. So we have to think in a more integrated fashion and more collaborative. I mean, you mentioned that I'm very interested in collaborative obstetrics, meaning that I work super closely with midwives, social workers, health educators, because our social workers, our role is only a piece of the puzzle. Women have been having babies, you know, since the beginning of time. Our bodies kind of know what to do. It's a lot about community and context for childbirth, and then integrating other people's other medical issues. So it gives me a lot of joy in my work.
Yeah, you and I have had a couple of conversations about this very issue, that people are not just, their height, their weight, the result of their
Right.
ultrasound, and their pap smear. They are multi-layered organisms that bring to their health their individual stories, so many different social determinants of health, what they eat, where they live,
Mm-hmm.
race, and we'll get to that, of course, and gender. Of course, you see only women,
Right.
but women, we all have unique facets of our lives that you can't possibly address in a single visit with a doctor, but that are the reason collaborative care is so essential. One of the best parts of my job, as I think it is for you, is working with the social workers, the
Yep.
therapists, the nutritionists, because it takes a village to help a person, right? I mean, it's
Mm-hmm.
taken a village. We've talked about our individual health journeys, and it takes a lot of different inputs and pieces of the puzzle to be healthy as a person. So tell me, what was your sort of day-to-day life like, Amanda, before the pandemic, before this COVID era? What was like a regular day for you like, and what gave you the most meaning during the day?
Mhm. It's funny because I've almost like had a bout of amnesia because COVID's like took over all of our lives.
Right.
But my day-to-days are actually incredibly varied. It's more like, what's a week like? So usually I work 2 12-hour days on labor and delivery. You know, doing all the normal stuff, taking care of pregnant women, taking care of postpartum women. And because we work side by side with midwives, it's all, the docs are doing all the high risk, stuff. And we are a tertiary care center with neonatal surgery and cooling. So we get some very sick patients and are able to take really good care of them. And then I do my local administrative work where we're working out, maybe a policy on how we're going to do inductions, or deal with an HR issue because a doctor and a nurse get into a fight with each other. Respond to patient complaints, or think about how we need to make the care experience better. So that's sort of my local administrative work. And then my regional administrative work is around care delivery in the prenatal and postpartum space. So before COVID, we were thinking about how can we connect with our patients better and make them feel more supported in the early postpartum period. My colleague, Allison Stubbe at UNC, who's the primary designer of the 4th trimester concept, it said, uses the analogy that a pregnant woman is like a fancy bonbon in a crystal dish. And everyone looks at her and she's so special and it's fantastic. And then you unwrap and open up the bonbon, take the bonbon out and throw the wrapper on the floor. And women are more than wrappers. And we have to put the maternal part back in maternal child health, particularly in the postpartum window. And so that was really what I was working the most on perinatal care design, and thinking about, is it emails, telephone calls, coordinating care with the lactation nurses, with mental health, catching peripartum blues versus depression. Putting that program together was really what I was working on. And then I think it's hilarious because it was an 18-month project to figure out how to do integrate virtual visits into prenatal care.
Right, and then recently.
I mean, honest to God, a 18-month project became a 1-week project.
Yeah.
And so I worked like a crazy person, coming up with at least a starting point. Fortunately, we have pretty deep analytical pockets within the organization. And so we had some of our analysts then go back, interview docs, interview patients, figure out what resources are needed, what's missing, what's working, what's not working. And so now we can go through this iterative process of looking at how do we need to make this, what do we need to make it sustainable? Because there were models all over, not all over, a few models in the country that were working, and what are the critical pieces that we need to support. And so now that we know that COVID's kind of here to stay, how do we look at how we're doing this type of care delivery? How do we give patients choices and consider the need for distancing to try to be efficient. And there's some people, you know, if you have a busy professional, someone who travels, she doesn't want to come in for office appointments. Like, it's her second baby, she had a vaginal delivery, she's fine. She doesn't want to come in. She'd much rather do it virtually. At the same time, we have to be super mindful of health disparities. And we already know that there are major racial disparities. With Hawaiian, Pacific Islander women, and African American women, their risk of death in the peripartum period, around the period around childbirth, is 3 times that of white women. And so
this is before the pandemic.
Before COVID.
Right. So we already knew pre-pandemic that the disparities along racial lines were egregious and something that was a major thing to deal with, and this is what you were working on.
Right. And so this is a big piece of my work. I lead a group called Health Equity for Women, and we are looking at what kind of programmings and how we cut our data inside the organization to really think about where disparities might be coming from. And then I recently joined the National Quality Forum with thought leaders from all over the country to look at how are we addressing disparities in the maternal health space. And so as we're doing so much care delivery redesign, we have to keep that in the forefront of our mind, and we can't make assumptions about it.
That's right.
It might be better for patients to not to have to leave their house because their kids don't have regular school, which parenthetically is so hard.
Oh gosh, absolutely. And harder for some people more than others, right? I mean,
totally.
So I want, if you could, Amanda, talk to me a bit more about, you know, the data among African-American women in the perinatal period, because, you know, when I remind myself of that data, it's astounding, and almost, you can't almost believe talking about a first world country like the United States where these statistics actually live.
Right.
And then I want to hear from you, if you could, about how the pandemic has highlighted those egregious statistics, and what you think the future holds. It's a huge question all bundled into one, but if anyone can handle that question, you can.
You're funny. Well, in terms of the data, it's actually regionally quite variable. If you look at the country, we are, the United States, one of the only developed countries. In fact, I think we are the only developed country in the world where overall maternal mortality is going up compared to 10 years ago. And then furthermore, if you are African American or Native American or Hawaiian Pacific Islander, your risk of death during pregnancy or the 60 days after is 3 times that of white women. And then your risk of severe complications is double. Now, there are places where it's quite different. I'm lucky to practice in California, where the rates are far lower than they are someplace like Texas or Florida. But the disparity, the gap is still the same. So the whole curve is shifted, but the gap is still the same.
And can I interrupt you, even though I don't want to interrupt you, but ask you, like, what do you think? What do you think that is? I mean, you know, there's lots of theories and hypotheses, but could you just wax poetic on what you think that is, and
about why maternal mortality is going up, or why the gap exists? Because it's two different questions.
Well, so why? So let's talk about first why the gap is. What's the gap? So, I think I know. I think I can answer some of it myself, but I'd like you to talk about it if you could.
So, I mean, the biggest thing around the gap is, well, two things. Well, maybe 3. One is access. So access to high quality care. Number 2 is trust, and people actually getting care from people who they trust and who they feel listened to. And then the impact of structural racism. And it's really important. And if any of your viewers are physicians, my biggest ask is, when you think about disparities, it is not about race, it is about racism. There is very little that's actually assigned to our DNA, and there are very few people, if any, in the United States who are like purely one thing or another. The United States is a group of mutts, right, in terms of our DNA. So it really is the structural racism that's created institutions, created implicit bias, housing laws, insurance laws, GI bills, all of these sorts of things contribute. So it really is the racism, not race. So please,
I think that is a great point, and I almost want you to say it again, but because it's such an important message, Amanda, and of course we're talking about it more and more now, and it's a very overdue conversation, and I think it's essential to realize, and particularly those of us in healthcare, when we're on the front line seeing patients in primary care settings, it's essential that we understand exactly that it's racism, it's not race.
Right. And so one thing I do with my medical students and residents, oh yeah, that's another thing I do. I forgot.
I know. Do you sleep? I don't think you probably sleep very much, my friend.
We have we have our own residency program, and then we also have the UCSF medical students can rotate. This is one of their choices for their OB rotation. But every time they come into a room with me and see an African-American patient, I remind them that you think about the fact that you may be practicing in Uruguay, right? If you were going on an abroad mission trip, you'd be thinking very differently about what the risks are. So I want them to think that they're in a population that is very risky. Or for example, if a woman is coming in with preterm contractions, her risk of a preterm delivery is double. If everything is the exact same, the cervical is the exact same, the contractions are the exact same, her risk of actual preterm delivery is double. So, without going into a lot of epidemiology around pretest probability of the adverse outcome, just to have that in your back of your mind, what is the likelihood? And I think there's so much discomfort around race and racism in the United States. People are scared to call that out. Well, I don't want to seem like I'm being racist and that I'm calling her more high risk just because she's Black.
But I think as you're saying, and as you've been so, helpful to me in talking about this over the last, couple of days and weeks is, it is an uncomfortable topic, but, you and I as physicians, I lost your cute face.
Shit.
I've got your name here, but there we go. As physicians, we talk about uncomfortable topics quite often. In fact, some of my, favorite, if you will, conversations are about death and dying, about, people's sex lives, gender dysphoria, patients who, reveal things about them that they're, that are very sensitive topics. So, it feels appropriate to me and to you, I know, to talk about race, because we have to face the fact that this is an enormous problem, not only in our country, but globally, that it is structural, it is baked into our system, and that if you as a doctor, Amanda,
right.
Oh, there's someone behind you. And I hope myself as a doctor can help people understand not only that we are layered, complicated organisms, but that race matters, and sometimes in an unpleasant way. But we need to identify our own biases because we bring our biases with us everywhere we go.
Right. And to acknowledge that it's not everyone has them. Right? And just because you have bias and just because racism exists, that doesn't make you a racist. And I think that is a big sort of judgment fear that a lot of people carry around.
Well, I think you're right. And I think that's why people are afraid sometimes of talking about it, because they don't want to say the wrong thing or put their foot in their mouth, because they're well intended. And I think, intention is a large part of this. But I think we need to be, as a white person, I come to this conversation with an enormous amount of humility. I am learning every day, not just right now, but, I feel like I hope my whole life about these issues. But I think it's important that we dare to be uncomfortable, because that's ultimately when we learn and grow. And just talking to you more recently has already been, enlightening. And anyway, so I think the healthcare profession, as you are doing every day, can help people in meaningful ways understand, how to talk about uncomfortable things and how to understand our own biases, and then how to understand the facts that there are real disparities in healthcare outcomes among people of color and in the African American community. That just is, and we need to address it.
Right. And to not be scared to say the wrong thing. And that's something that we can do is, you know, certainly starting in medical school and having those conversations and then just having them at your dinner table. And asking, you know, hey, to your kids, you know, so what do you think about this? Or thinking about who are your kids playing with? What does the diversity look like at your kids' preschool? What do the dolls look like? This is a little bit of an aside, but when my son William, who's about to turn 16 next week, and I'm terrified. But anyway,
yeah, you should be terrified.
when he was in preschool, he had all these stuffed animals, and he had set them up in different kinds of families. And so he's like, this is the grandma family that goes with the kid, with the baby panda. This is a 2-bear daddy family and goes with the little panda. And so he had designed different kinds of families with his stuffed animals. And that is because that's what was in his preschool. And it was so, I mean, I was like weepy, terrible mess.
It makes me want to weep right now. So yeah, it's just like amazing.
But, you know, we picked his preschool with intention, and like homophobia is not something, he knows that it exists, but it is also so, different kinds of families are so normalized in his life because that's what he was exposed to when he was 3.
Right.
And the rest of his life. So I think if we're really intentional, what are your kids reading? Who are they playing with? What do their dolls look like? What are the conversations like at your dinner? Who's coming over to dinner? I mean, just those little simple things actually add up over time.
Right. And it's so important for parents to talk about it with their kids, as you're saying, because we learn so early on, just by observing how our parents behave and who they socialize with and how they talk about these things. But it's also, as an adult, it's never too late to learn, right? Even as an adult, with like, you know, we were talking earlier today about it's hard to teach an old dog new tricks, you know, but it's not impossible, right? It's not impossible. Exactly. I mean, I feel like, you know, it's a journey of being a human being every day. And, you know, I do think that we can learn from each other, even if we're, you know, older. And of course, I know you agree with that, but tell me, Amanda, what do you find COVID, the pandemic, and then, I mean, you know, before this enormous surge of trauma once again to the Black community, and not that it's not been lifelong, but the sort of intense focus on it. You know, before that we had the pandemic, and now we've got, you know, so much going on all at once. Like, how is this affecting your patients, and then how is it affecting you as a doctor? Like, what is all these different layers? And this is not to say that structural racism hasn't been around forever and that the trauma the Black community has felt is daily. I'm just saying, what is the sort of energy like among your patients and for you as a doctor? I
mean, I had a day, I'll say a week or 2 ago, where every single one of my patients cried. Like an entire half day. I saw 12 patients, all pre or post birth, and every single one cried.
And these are women of color, white?
Well, it was a mix.
Yeah.
It was a mix. And across the board, everyone is rattled.
And were you crying with them, or were you?
I was trying to keep my you-know-what together, and then went home and cried.
Yeah, that's what we do sometimes, right? We just kind of, you kind of fake it, and then you get home and you just fall apart.
Yeah.
Or you fall apart in the moment, that's okay too.
Yeah, I know, every once in a while, you know, I do, especially with my residents. I try to, you know, show strength and vulnerability, especially because we don't have the answers to so many things. But, you know, pregnant women are an anxious group at baseline.
Yeah.
And so you throw this extra layer. I wish, and this is actually one of my big flag wavy points of all of my career.
Bring it.
That I wish women cared about themselves enough to give themselves the best all the time. However, when they are pregnant, they tend to be extra motivated to take care of themselves because they're taking care of their fetus also. So I want to capitalize on that. And, you know, historically, we capitalize on it in terms of, hey, great time to quit smoking. Hey, let's eat healthy. Let's exercise more. But now they're just sort of in survival. You know, I don't want to leave my house. And so trying to convince a woman, okay, get up at 6, go for your walk, is still a healthy and safe, you know, thing to do. So everyone's just really struggling with that. Then on top of it, you know, birth is supposed to be a happy event. And it's one that is mediated by culture and community. And when people can't have their community and feel detached or isolated from their culture, it sort of undermines part of the beauty of this new being coming into the fold. And so that's causing a lot of sort of distress and discomfort.
And
then
wonder if I'm saying that worrying about bringing a newborn into the world that we live in.
Right. I mean, people who've been delivering the last few months were already pregnant. So you can't just like not be
turn it
pregnant
off. Yeah.
when you're 6 months pregnant. You can't,
right.
It's not like you can put off your pap smear for a few months. You cannot put off the fetus growing. Like it's just gonna happen. So then the patients who have the extra layer of race and knowledge about maternal morbidity and mortality on top of it is incredibly scary. And patients come into my office and, you know, I have a bit of a reputation, so people will come and seek me out. Like, look, I know that Black women are more likely to die. I need you to take care of me. I mean, I remember once I had a patient who's had a pre-op with a colleague of mine. And I heard she had an appointment with me, and I was like, oh, I'm so sorry. I'm actually not the one doing your case. And she goes, that's the problem. I need you to do my surgery. And I was like, but it's real. And so you take those double layers of COVID and the race-based maternal morbidity and mortality associated with being an African-American, that it's really doubling down for patients. And then convincing them that they are safe in the hospital. I mean, we take so many precautions, and we've actually had 0 internal conversions. So meaning
you guys are being very, very safe.
Right. And we are fortunate enough to have really good PPE. It's not limitless. So we have to be conservative and we have to be mindful about our use. But, you know, there are hospitals, small hospitals in New York where people are using trash bags. And, you know, reusing like one, not even like respirator for a week. I mean, there are places where it was really bad, but we've had no healthcare worker conversions in our service area. And, you know, prevalence is relatively low still in Northern California. So reassuring patients that they are safe has been a body of work. And then reassuring staff, because our nurses are terrified and recommendations keep changing. I mean, even from, you know, CDC, county public health. So it's a time of a huge amount of anxiety. And then for those who have the doubling down of all of the energy on race right now, sort of adds another layer. It's not that anything has changed. It's just that it's now being captured on video. And so some of the more egregious behaviors are in our face.
Right. Just that we have now, you know, the ability to videotape these things. And you were saying to me last week how, I mean, and I don't want to speak for you or reveal, you know, your personal, you know, comments to me, but just that the sort of pressure you were feeling and are feeling as a woman in your role as a doctor, and to be vocal about these issues when sometimes you just want to like not talk about race all the time because it's something you live with every single day. Again, I don't want to put words in your mouth, but just, you know, it's not like this is new.
Right.
Yet you now have this like added job of like speaking, you know, to the issues that are front of mind for everybody.
Mm-hmm. Well, and that's on one hand, it's great seeing that more attention is going, but I don't need email from every organization that I've ever like bought sneakers from. That is not helpful.
Yeah. I'd love to talk about that. Keep going. Keep going.
I want to see action. I want to see people doing their work. And I'm here for the marathon. I am not here for the sprint. And so, I mean, I told you that there was a day of like, I just cannot be in this space anymore. And so I took my kids and we went up to the redwoods and we went for, you know, a long hike, and it took me 3 tries because there were police barricades at 3 different exits on the freeway. But I have to make this sustainable for myself. I've already committed my career to health disparities. I already know that my kid is about to get his driver's license, and he is 5 times more likely to be assaulted by the police than his white peers. And his little private school education is not gonna save him. So that is terrifying to me, but I was living with that far before there were protesters in the street.
Right. And I think, you know, what I'm hearing so much from my Black friends is exactly what you're saying, that, you know, while it's lovely to, you know, repost and regram and hashtag, you know, and those gestures do have meaning, and it suggests, and it means that people are paying attention. But what really needs to happen is action, and, you know, putting your money where your mouth is, and having the conversations that are hard and leaning into that discomfort. I mean, at least that's what I feel like I need to do to actually, you know, deliver on the message that I put, say, on Facebook. Is not just the message, it's the doing.
Right. And that's what I'm really hoping will happen. And I, you know, I'm trying to call this strategic and not call it manipulative, but I've been trying to be very targeted about who I dive into conversations with.
I'm so honored, by the way, that you're talking to me about
it. You get to be one of those people.
So, no, seriously, Amanda, I know your time is very little. I don't know how much you sleep at night. It can't be that much. So here and being with me in the past couple of days and weeks talking about it, I mean, it's just like the bee's knees.
Yeah, thank you. I mean, I try to really talk and invest in people who I think, 1, are genuine, 2, have started doing their own work. Like, if this is brand spanking new, we got too far to go. Like, if you don't even
control,
have this on your
delete,
radar, this is not me. And people who have reach. So if it's someone who I know, you know, would, you know, watch a video and then send it to their, you know, practice group or their patients, or, you know, have some, I had a couple of videos and resources that I sent to the chairman of the chiefs of OBGYN, and then she sent it out to another 500 people. Like, that is who I want to invest in, so that messaging can go further. Like, for me, I mean, there is value in protest. There's value in drawing attention. But for me, that is not how I best use my time. I have to think about what is my unique contribution. And my unique contribution is around messaging to senior leaders or people who have wide social and professional networks. Number 1. Number 2, to mentor and develop the pipeline of African-American physicians. And then also to just keep disparities in mind with whatever programming's being done, and to talk to it. So, for example, if you're doing recruiting, and I'd even say this to you, Lucy, if you have a doc retire.
Which I am doing right now. Yes.
Right? If you have a doc retire in your practice and everyone who's applying for the position is a white woman, you know you don't have the true denominator. So
that is it. And I'm in that position right now, and don't you know, that's what that's it. I mean, that's it. We don't have the denominator.
Right. So it's not saying who you have to hire, because that's like an HR problem.
But you have reach.
Right. You have to at least know you have the true denominator. And there's plenty of research about having women and people of color on boards of major corporations. They tend to be more successful because you have diversity of thought, diversity of opinion. So something as simple as that, like any open position, if you're like a person of power who hires people, any open position, make sure that you're interviewing at least one woman, at least one person of color. Like that's not that hard.
It's not that hard, and it's a great message. And it's I mean, like this whole message that you're giving me today, I mean, I'm going to share it with everybody I know, whoever will listen, because these are important messages. And I want to kind of, at the end, I want you to kind of go through your like bullet points, like strength and vulnerability, you know, putting yourself first. Don't make pregnancy the only time you take care of yourself because you matter all the time. You know, I want you to kind of give the top 10 Amanda Williams, like, but anyway, did I lose you? I think I lost her for a second. Hello. Let's see. Just as we were getting going, if I lose her, I'm going to just stop and start. Don't go anywhere, people. We're just getting going. Can someone text me on Facebook and tell me if it's still live? Here's what we're going to do. We're going to stop and start again. Let's see. I'll be right back, everybody. Hold on.